We're going to kick off the afternoon session. So if everyone can take your seats. All right, so this is a lineup of my colleagues who are experts on various fields, and they're going to review some of the screening guidelines across different cancers. And a lot of these guidelines have been evolving and changing, so this is to really get us all up to speed. Our moderator today for Screening Guidelines 101 is Dr. Christopher Anker. Dr. Anker is a radiation oncologist at the University of Vermont Medical Center and an associate professor at the Larner College of Medicine at University of Vermont. He's a member of the multidisciplinary lung, GI, central nervous system, and head and neck teams, and the leader of the skin and melanoma multidisciplinary team. He serves on several national cancer committees, and he's been involved in writing treatment guidelines and developing clinical trials. So we're very honored to have him here, and I'm going to just introduce the rest of the panel. So Dr. Anker is joined by Dr. Charles Ashley, who is UVM's newest gynecologic oncologist and a Larner College of Medicine alum. Dr. Ashley returned to Burlington in 2021 upon completing residency at University of Wisconsin-Madison and subsequent training at Memorial Sloan Kettering Cancer Center in New York. He's an assistant professor in the Division of Gynecologic Oncology for the Larner College of Medicine. Skip ahead so we go in order. So Dr. Hannah Kooperkamp joined the University of Vermont just over a year ago after completing her cardiothoracic surgery fellowship at Tufts Medical Center. She is an assistant professor in the Larner College of Medicine and a CT surgeon for the UVM Medical Center. Dr. Kooperkamp has interest in lung and esophageal cancer, as well as minimally invasive approaches to thoracic surgery. And then we're also joined by Dr. Jeremy Dressler, who is a colon and rectal surgeon at the University of Vermont Medical Center and assistant professor of surgery at the Larner College of Medicine. Dr. Dressler specializes in laparoscopic and robotic colon and rectal surgery, and his research interests include patient frailty and surgical cancer outcomes, and he also has interest in surgical and medical education. So thank you all in joining our panel.
Right. Thank you, Dr. Gonzalez, for that kind of introduction and the opportunity to speak today. So yes, as a radiation oncologist, I get to work with all three of my esteemed colleagues here and helping patients through the whole process. And one of my particular interests clinically and research is to avoid unnecessary cancer therapies that just might not be quite in line with people's goals of care. And even better, though, is preventing the need to treat the cancer altogether. So hopefully we can all make some progress to achieve that goal. I'll be giving a very high-level overview right now, and then we'll get into the details of the various screening guidelines with my colleagues in just a moment. So broadly, I'd just like to touch on what is cancer screening? Why do we screen? What cancers do we screen for? How are screening tests chosen? And how are screening tests assessed? So screening, as you heard about before today, it's determining whether a cancer is there before any symptoms are present. So once you have rectal bleeding and then you go in to get a scope, that's not screening anymore. That's really more of a diagnostic scope because there's a problem. We want to prevent that bleeding. We want to prevent that problem from happening. So there could be various diagnostic tests that are done, imaging tests, CT scans, mammograms, lab tests, like fecal occult blood tests, direct visualization, like via endoscopy, and perhaps tissue sampling, like a pap smear, and maybe if a biopsy is done. Now, for those of you who attended this morning's sessions and heard Dr. Nikki Sideropoulos talk, and also some others, there are some exciting options possibly coming down the pipeline, such as liquid biopsies and artificial intelligence helping improve our means of diagnosing various malignancies. But for right now, we're just kind of telling people what is the landscape right now for what the options are, because it's such a balance between so many items when it comes to assessing what screening tests are appropriate. Now, why do we screen? It's to detect cancers early, or maybe they're precancerous lesions, so they're easier to treat and to cure. And, really by the time symptoms appear, sometimes those symptoms may be reversible, but sometimes not. So we sure would prefer that those symptoms never happen for our patients. Really the cancer could have grown, spread, making it harder to treat and cure. And, then of course, not just symptoms from the cancers that could be permanent, but the permanent side effects that could result from those treatments. We would prefer to avoid all that if we can. So just as an example as to why do we screen, this is a graph on lung cancer screening, and the text is small, forgive me for that. But what you can see is just this decrease in the incidence of really advanced cancers over time. I apologize, go back one. Now, this distant means distant disease is spread throughout the body. There's a sharp decrease in the diagnosis of distant cancers after this initiation of lung cancer screening, and also the regional, basically if disease has spread to lymph nodes, there's a decrease in that over time, and an increase in the diagnosis of localized disease, meaning the tumors have not spread. Now, overall, there's a general decrease in the incidence because of a decrease in smoking as well, which has helped. But you can see these more sharp changes indicating more cancers are being diagnosed at a treatable and really curable setting. And that's also evidenced by the fact that the overall survival in general for lung cancer patients has improved over time. It used to be pretty low, certainly it's harder to cure it when it's spread. And then it's gone up about 10% since the screening guidelines have been implemented. And Dr. Kooperkamp will get into that more shortly. What cancers do we screen for? There's so many cancers, of course, that we can't really do a great job screening for right now. And maybe with Dr. Sideropoulos' options for liquid biopsies, we might have better options in the future, but we also don't want to just screen for these cancers that, may lead to unnecessary biopsies and tests and treatments that might not be effective. So we really right now are focusing on what can we really have a nice balance between accurate and safe screening tests that improves outcomes and minimizing patient stress. And, what we're focusing on today is lung cancer as really one of the most common and also the most deadly cancer out there. And we're also focusing today on colorectal cancer and cervical cancer. And you do see, though, there are a lot of other cancers on this list that are diagnosed, that are pretty common and maybe deadly, such as pancreatic cancer. And there are active research studies going on, even at UVM, looking for biomarkers and tests that we can do a better job on that. But for right now, these are the ones that have that, the best balance between can you find it and can you do something about it that truly improves a patient's quality and quantity of life. So how are these tests chosen? Just to go on, continue what I was just saying, you want it to be a minimal bother to the patient. And ideally, you're catching every cancer every time. That would mean 100% sensitivity. Also, every negative test is truly correct. That would mean that it's a perfect specificity. But in reality, tests aren't perfect. There are really good ones out there, but it's a balance between these factors. And you've probably heard some terms today, such as false negative, false positive. And I just want to give a little more insight as to what that means. I think many of you know in general what that means. But when you talk about sensitivity of a test and specificity of a test, I'd like to just give you a little more insight as to what that might mean to you as you're going through these tests, or if you're a provider as you order these tests. So for this group of 10 people, consider a situation where all 10 have cancer, and the test says that 8 of them have the cancer. So it missed 2 of the 10. And therefore it's 80% sensitive. So the sensitivity is the number of true positives over the true positives plus the false negatives. And so if a test is really, really sensitive, that means it's really good at being negative only when the disease is not present. So if you have a negative test and it's really sensitive, that's excellent news because it catches just about everything. So if you have a negative test, meaning it's not present, you're in good shape that you don't have that test. Now, sometimes you can have tests that are too sensitive and you might end up with more false positives. So then for specificity, that's identifying those without the disease. And so, for this test here, everyone doesn't have the disease. It has 3 people that actually were said to have it that don't have it. So that's not great. It's a 70% specific test. Really what you want is a test that's so specific that it's only positive when you really have the disease. And so if you have a really good specific test and it's very specific, it's only positive if you have it, and it's negative otherwise. So that is a good test, meaning that, so if you get that test done and you get that positive, well, you're not being led down this rabbit hole of all these other biopsies and tests that could be very expensive and time consuming and stressful. So it's good to know what is what as a provider and a patient. So you just are able to interpret those tests better, especially in this age where you get results immediately, sometimes before a physician has the time to talk about it with you. All right, with that overview, I'd like to pass it on to Dr. Ashley. And I need to just switch to your slides, and then you're good to go. Okay.
All right, and thank you for the invitation to talk today about gynecologic malignancy. And although I will spend more time on cervical cancer, where that is where we have the most amount of data and screening options, I did want to take the opportunity to talk briefly about the other cancers that I treat. I somewhat uniquely in the world of oncology do both surgery and give chemotherapy, but in full disclosure, I do not do a lot of screening, and a lot of the screening is done by my general OBGYN colleagues in the field. So primarily the four cancers that I treat are uterine, ovarian, cervix, and vulvar cancer. There is vaginal cancer as well, although that's almost like a subset of vulvar cancer in some ways, and even more rare than vulvar cancer. So you can see that cervix cancer, and these are numbers for the United States, is not even the most common cancer within the gynecologic organ system. So, however, cervical cancer is the most common worldwide gynecologic cancer. And then I just wanted to note here that although rates are going down for cervical cancer, ovarian cancer, it's actually uterine cancer that the rates are going up on, and that has to do with the fact that primarily endometrial cancer, which is 90% of uterine cancer, is made up of folks who have their cancer developed from risk factors that include obesity. So I'll talk a little bit about each of these, but then spend the most of my time on cervical cancer. So, and then just a few notes beforehand. So as far as general wellness screening goes, it's interesting when we look from a data-driven standpoint, and the USPSTF agrees that without any real reason, annual pelvic exams don't really need to play an uncertain role in their ability to detect malignancy for women. And then and again, we'll kind of circle around to this, but for women who have a family history of an ovarian cancer, a first-degree relative, those are folks that should go to genetic counseling. Everybody. It doesn't matter if you have a history of a BRCA mutated family member. Because the rates of cancer are so high, and it substantially changes our recommendations, anybody who has a first-degree relative with an ovarian cancer should get screening to potentially see a genetic counselor. So uterine cancer, the most common gynecologic cancer in the U.S., there is no universal screening recommended. However, this cancer primarily presents at an early stage because people come in with abnormal uterine bleeding or abnormal vaginal bleeding. And so if women are premenopausal and have additional risk factors, those are people who should get worked up for uterine cancer. Those risk factors include excess estrogen. So I alluded to one of those risk factors, which is obesity, but also things like taking tamoxifen for breast cancer treatment, if people have never been pregnant, or women who are on hormone replacement therapy. And then diabetes, hypertension, and genetic predisposition to uterine cancer should also be considered, even if they're in a premenopausal age group. And then anybody who is any woman who is postmenopausal should be evaluated for uterine cancer. And the way that that's done is through a transvaginal ultrasound in order to measure how thick is the endometrial layer, again, because primarily uterine cancer comes from this inside layer of the uterus. And so women who have a thickened endometrial stripe should have sampling of that tissue so that a pathologist can look to see if there are abnormal cells there. We're fortunate in that the vast majority, again, these cancers are caught early and are treated with surgery. And if caught early, that can be the only treatment that people need. Switching to ovarian cancer, again, no universal screening is recommended. And ovarian cancer is probably the most challenging cancer that I treat, in that the vast majority of the symptoms that people have with ovarian cancer, which is why it's termed the silent killer, is that they're not very nonspecific, and often people associate these symptoms with just part of normal aging process, things like feeling bloated or, increased abdominal girth, changes in how your bowels are functioning, whether or not you're having to go to the bathroom more often. These are all really common things. If you look at people who go to a primary care physician office, over 90% of people will have at least one of these symptoms within a year. So it's very difficult to suss out who should be worked up for an ovarian cancer. And so, and when we look at ways that we can screen or possibly could screen for ovarian cancer, getting back to what Chris was talking about, all the things that we looked at, none of them were really viable ways to screen for this cancer. So primarily the things that we spent the most time looking at are transvaginal ultrasounds to look at the ovaries, or getting a CA-125 level, which is the best tumor marker that we have for ovarian cancer currently. Neither one of these, even in a high-risk population like women who have a BRCA mutation, have not been shown to be beneficial as far as an overall survival or or diagnosing the cancer earlier, unfortunately, which is really challenging, especially for folks who are in those high-risk populations. Vulvar cancer, rarer than the other two, also no universal screening recommended, although you could argue that maybe this would help prevent people or would help justify routine pelvic exams. Is that vulvar cancers start out as some sort of new spot on the vulva, or people have things like itching, bleeding, or pain, and really the only way to work these things up is biopsying. All right, now getting to the meat of things. So cervical cancer, so where we do have universal screening recommendations, and we do that with a combination of both pap smears, which is this brush here you can see, where we are trying to get a small number of cells off the surface of the cervix and also from the glandular inner portion of the cervical canal. And we look at those underneath a microscope in order to determine if those cells are abnormal and if you need further testing. Now, and then HPV, because HPV is the primary driver of cervical cancer. And I'll get to why that is in just a moment. But as far as risk factors for cervical cancer, you can see here, there are things like early onset of sexual activity, multiple sexual partners, high-risk sexual partners, history of STIs, and a number of other things. And just to get on my soapbox for a moment here, instead of focusing on whether, what a woman's sexual history is, maybe we could stop sex shaming them and focus on what the real highest risk factor is, which is that not getting the HPV vaccine. So some details on that. Australia was the first country to initiate national publicly funded HPV vaccination. And the current non-valent or 9-valent vaccine for HPV also includes a couple different subtypes that encapsulate genital warts, and they've seen a rapid decline in genital warts, and similarly which was more short term, but then they've also seen a steady decline in the rates of cervical cancer, and they've gone all the way from 15 in 100,000 down to 6, and they anticipate it'll be around 1 or less than 100,000 by the year of 2060. That's just with universal vaccination. This is a preventable cancer. right? When we talk about other cancers, we fixed this one, and now all we need to do is change minds of people around getting vaccination. But unfortunately, the last few years have only further complicated that discussion. So the way that HPV ultimately leads to cervical cancer is that the virus gets into the cells in the transformation zone of the cervix and disrupts the cell's ability to regulate replication, which ultimately leads to more mutations in the DNA of the cells of the cervix. And so more mutations ultimately, if they accumulate, can and lead to a formation of a cancer. And so depending on which of the governing bodies that you believe the most in, everybody kind of recommends some amount of HPV or PAP, or essentially starting at the age of 21 or 25, going all the way to the age of 65. And really, you should kind of pick whatever is cheapest and most available. I think the issue that some people have seen is as we get more and more data, as we do more and more vaccination here in the United States, the need to constantly get PAPs or constantly do HPV testing has been spaced further and further out. But then people like myself get paranoid that we're missing some of these cancers that can occur faster. And so some bodies have then decreased from 5 years back down to 3 years again. But all of these are acceptable screening methods. It's really the combination of both high-risk HPV testing and Pap smear and following algorithms. And the ASCCP is probably the most commonly used algorithm, governing body algorithm that most OBGYNs use. And the algorithms change so quickly that most of us at this point in time just all have an app that you plug in what people's age is and what their recent PAP tests are. So I'm not going to spend too much time in the nitty-gritty part of that, but something that Chris did mention makes me want to bring this up is that, you know, screening tests should not be particularly invasive, and yet here we're talking about pelvic exams with Pap smears and which is fairly invasive. So we are looking at other ways to try to evaluate for this kind of testing. HPV DNA testing, as DNA testing gets better, could be done from urine. It could also be done from tampons. It could be done from a number of different sources. And so we're not quite there yet, but there are a lot of really intelligent people working on that to try to make this even less invasive than it already is. And so if those tests are abnormal, generally people end up getting colposcopies, which is just a microscope to look at the cervix. And symptoms for cervical cancer, early cervical cancer can often be asymptomatic. And then if you have a visible lesion, it can be seen at the time of pelvic exam. Some people can have irregular heavy bleeding or bleeding after intercourse, or have really abnormal discharge, primarily watery or purulent, something mucus or foul smelling. These are all reasons that you potentially get somebody out of the normal algorithm and get checked out sooner. And so we are fortunate that this is generally a slow process. And I did want to point out, because it's often confusing even for folks that are in the field, but the PAP tests, your results come in as like a low-grade squamous intraepithelial lesion or a high-grade, but then it's this separate biopsy diagnosis that you're getting when you're getting a colposcopy and a cervical biopsy, which is cervical intraepithelial neoplasia, CIN. It's graded 1 through 3. You can kind of see where the histology here overlaps with CIN 1, 2, and 3, and HSIL and LSIL. And some of these things will regress as people clear the virus. But in general, if left untreated, things will progress. And the further along, the less likely that the abnormal cells are going to progress. And this is primarily 2 separate types of cervical cancer. Both are primarily HPV driven, squamous cell carcinoma being the most common, which are the cells on the outside of the cervix, and then adenocarcinoma, which comes from the inside of the cervix. And then just one more little thing, it's a question that often comes up, is what if I've had a hysterectomy? Should I be getting pap smears? And the answer is only if you had a history of abnormal paps where they did a biopsy and you were in that CIN2 or CIN3 category. Otherwise, people are done and you shouldn't have to have any more pap smears at that point in time. So unfortunately, I have to run to the operating room. So if anybody has any questions specifically for me, I'd be happy to answer them.
This is from somebody online. At what age are pap smears not necessary? / how old to stop with annual pap smears?
Yeah. So annual, nobody needs annual unless they're abnormal, but 65 is generally where most groups recommend that you can be done with screening pap smears. No.
They don't have cervix left because of hysterectomy. Just getting
I couldn't quite hear everything, but I think I can repeat what I believe you asked, which is, am I talking about hysterectomy for a cervical reason or?
No. So if they've had a hysterectomy and they don't have a cervix, are you just swabbing the vaginal cuff that's left, or are you talking about with cervical preservation?
Yeah, good question. So I'm talking about the vaginal cuff. So there is such a thing as a supracervical hysterectomy where the cervix is spared. As a body in medicine, OBGYNs and certainly gynecologic oncologists have moved further and further away from supracervical hysterectomies. One, because it doesn't always fix the issue that the hysterectomy was done for. Women will often, as many as 40%, continue to have abnormal bleeding from a cervical stump. And that's one of the most common reasons that we do a hysterectomy. Two, it can often make a lot of the diagnosis of some of these things more challenging if you don't have the body of the uterus anymore. And at least for a lot of the indications that we've looked at, we haven't seen a lot of difference in quality of life with or without a cervix remaining.
I think we just had time for one more.
My question is, if a person has a negative HPV test at any age, as opposed to just a teenage girl who we're normally trying to screen and vaccinate, can they get a vaccine? Can they ask a provider for a vaccine at any age if you test negative?
Yes, absolutely. Even if you test positive, you can still get the vaccine. The vaccine is typically given in 3 doses. I can tell you that I got a vaccine not that long ago, right? It's now opened up the indications for who can get a HPV vaccine. I see no reason why anybody should not be able to go to their provider and ask for it if it's something that you want. And sometimes we'll even give it to folks who have abnormal types, because it's a multivalent HPV vaccine. And even if somebody had an abnormal one type of HPV that drove their cells to be abnormal on their cervix, you still could potentially be preventing them from a number of other high-risk HPV subtypes.
Awesome. Thank you.
Thank you, Dr. Ashley.
I'm Hannah Kooperkamp. I'm a thoracic surgeon here. We're going to talk about lung cancer screening. So this is what a lung cancer screening may look like. So lung cancer screening is very important because lung cancer is very bad. Not to brag in terms of the other cancers that we talk about up here, but lung cancer is still really deadly, leading cause of cancer death in the United States. And most people who are diagnosed with lung cancer are diagnosed when it's not localized disease anymore. So when it's much harder to treat, when it's much harder to cure. We didn't do lung cancer screening until about 10 years ago after the results of this national lung cancer screening trial. which showed a 20% decrease in mortality, which also, not to brag, is much better a decrease in mortality than you get with the screening from the other cancers that we talk about as well. And one of the things they showed, just sort of a little bit funny to think about, you need to screen 323 people to prevent 1 death from lung cancer, which in the world of screening is not that many people. And sort of the other ways that they tried to screen before, and just for a little bit of history there. So chest x-ray doesn't help, and that's what that study was comparing it to, chest x-ray and CT scan, which is how we screen. And different ways trying to look at sputum also didn't help in terms of lung cancer screening and finding these early stage lung cancers. Most people who have lung cancer either are still smokers or were former smokers. And most people who get a lung cancer are diagnosed at an older age. So the median age of diagnosis is 70. So if you think about that in terms of who we're going to want to screen, so we want to screen people who either are still smoking or were smoking. And you want to start screening them sooner than 70 because you want to find them before they're at this advanced stage. So by the U.S. Preventative Services Task Force guidelines that were updated just less than a year ago, or over a year ago, we want to do annual screening for lung cancer in adults who are 50 to 80. So they lower the age, which had previously been 55. And if they have a 20 pack year smoking history. And how we calculate pack years, so if you think about somebody who started smoking at age 15 and quit smoking at age 35 and they smoked a pack a day, that's a 20 pack year history. If they smoked half a pack a day from 15 to 35, that's a 10 pack year history, so they wouldn't qualify. So if they still smoke, or if they quit within 15 years, that's a long time. So if you have a patient, or if you are a person who is 50 years old and you quit smoking 10 years ago when you were 40, which is great, it's a hard thing to do, you still likely qualify for lung cancer screening. So again, they lowered the age from the previous recommendations from 2013, because 2/3 of the people who are being diagnosed with lung cancer wouldn't have met criteria from their previous criteria for screening. So we're trying to catch more people and again, find more early stage lung cancers that are much more treatable. So we screen with putting someone in a CT scanner and then having somebody look at the pictures. You don't need an IV for this kind of screening. It doesn't use IV contrast. It's just a CT scan. I'll talk a little bit about the radiation more, but it's a low dose CT, so less radiation than a regular CT scan. And after you get lung cancer screening, you get a lung RAD score. So we talk about BI-RAD score, breast cancer, TI-RADs for thyroid cancer, and we also have a lung RADs now too. And it's going to give you a score based on what they see on the CT scan. And depending on the score, you can see there are different risks of malignancy. And most people are going to be are going to be a score of 1 or 2. So less than 1% risk of malignancy, and that's going to be 90% of the people who have lung cancer screening have less than 1% of risk of malignancy. And as you move up into a 4A or 4B, which will be 2% and 2% of people who are screened, the risk of malignancy increases, and sort of what you do there increases. And that's looking at what they find in the CT scan. So most of what we find are nodules, and they're more and less solid nodules. And they're looking at the size of the nodules and the different characteristics of it and giving them that score. So this is what you might find in a CT scan. It's always hard in a still image of a CT scan to see, but these white parts are mostly blood vessels. But if we scrolled up and down on the CT scan, you could see that this part is a nodule. It's not connected to anything else. And so this is looking at the left lung over here, and there's that nodule over there. That's what you might find on a low-dose CT. So after you get a low-dose CT done and you get your lung RAD score, you'll go sort of one of a few different ways depending on what you see on it. Either it's hopefully, and this is the majority of cases with these, nothing that needs any further follow-up. You continue the annual surveillance, you get another CT scan in a year. Or depending on what you see, maybe you want to keep a closer eye on it. Either you do a 1 month or a 3 month or a 6 month CT scan from there. Or depending on the suspicion of what they find too, might get a PET scan, so a different kind of imaging modality, depending on the size of what you see. Or it could be something that you need to get a needle biopsy for, or a biopsy where they go bronchoscopically down through the airway, or a surgical biopsy, where I might come in there. So when we're looking at these nodules in real life, so this is the chest wall, this is the lung, and that's what a nodule would look like, a kind of peripheral nodule, an early stage lung cancer that we're trying to find. You can take those out. So risks with lung cancer screening, there's always a risk with any screening test of having a false positive, like Dr. Anker talked about some, or thinking that you have something that you don't, which is pretty distressing. When you look at lung cancer screening, the risk of having a false positive, is highest on your first screen. So while you're still sort of getting to know what's present there in somebody's lungs, and then as you get more screenings and you know sort of what nodules were there, what things were there, that risk of having a false positive is lower with the subsequent tests. And using the lung-RADS scoring system decreases the rate of false positives. So again, there's psychological distress from having a screening and the uncertainty there. I think there's more psychological distress from having undiagnosed lung cancer. And there's some radiation exposure associated with it. It's 5 times less than a regular CT scan that you might get for other reasons. But there is a very small risk of having a different kind of cancer develop from having the radiation from it.
Thank you, Dr. Kooperkamp. So Dr. Dressler, could you come up and present next, and then we'll have questions after that. Thank you.
All right, good afternoon, everyone. Thank you for the conference organizers for the opportunity to present today. As previously mentioned, I'll be talking about colorectal cancer screening. Just to kind of talk about briefly what we'll be covering. So first, we'll talk about colorectal cancer, what it is and what the burden of disease is in the United States. We'll talk about what screening tests are available, as well as the most up-to-date guidelines for screening. So first off, this is just a diagram here depicting what the colon and the rectum are. And as you can see over here, highlighted in green, it's the end of your GI tract. So everyone's lunch is probably somewhere in their stomach or small intestine here in the middle, and slowly working its way around to the colon. And then the rectum is the last piece before your GI tract ends. In terms of colorectal cancer, at least talking in general terms and for what's kind of the most common form of colorectal cancer, these tumors start as polyps, which you can see here depicted in the colon, and eventually grow into the wall of the colon. And if not picked up or treated, can turn into ugly looking tumors like this, which then have the ability to spread to lymph nodes, to your liver, to your lungs, and can cause pretty significant morbidity and mortality, as Dr. Anker previously mentioned. In the United States, we see a pretty high prevalence of cancer, colorectal cancer, excuse me, with an annual incidence around 150,000. Now, the data presented here are old from the American Cancer Society. They kind of do every couple of years put together a new report. And so this is a report that ended with 2020 projections, as well as about 50,000 annual cancer-related deaths. Now, what's interesting about colorectal cancer, and we'll touch on in a little bit, is that the overall incidence is actually decreasing thanks to screening, but we are seeing an increased rate of diagnosis in younger patients. Previously thought it was supposed to be a cancer of patients over the age of 50, but about 12% of cases have been diagnosed in the last year in patients under the age of 50. And this is a doubling. So before it was 6% since 1990. Overall lifetime risk is about 4%, slightly higher in males than females, but it's roughly equal. And just looking at the trends here, and this is again thanks to screening, what we can see is that the incidence, so the annual number of cases diagnosed, has drastically decreased in about the last 50 years or so. 50% reduction, and then mortality is also slowly decreasing as well. And that's thanks to early detection as well as changes in cancer treatment. All right, so let's talk about approved screening tests. So first, we'll talk about colonoscopy, which many of you have either had a colonoscopy or know someone who's had a colonoscopy. And this is definitely the most prevalent screening test used in the United States. It's an endoscopic procedure, meaning we use a flexible camera inserted through the rectum, and this is either performed by a surgeon or a gastroenterologist. The biggest complaints with it are that it does require a day out of work. You have to take a bowel prep, which it can be pretty miserable the night before, the day before. But it does look at the entire colon. And it has the unique ability to not only find polyps or diagnose cancers, but also remove polyps, which are precancerous lesions. And the general recommendation is a colonoscopy every 10 years if there are no significant findings. Sorry. Sigmoidoscopy is kind of a modified version of colonoscopy. It only goes kind of in the last third of the colon. It can be done without anesthesia, so you do not have to take as much time off from work. You don't need as much of a prep, but it's really fallen out of favor because, again, you're only looking at about a third of the colon, and you can certainly miss a lot of polyps and cancers that way. Moving into the kind of newer technologies, we have an imaging test called the CT colonography, often referred to as a virtual colonoscopy. And this uses a combination or uses a CAT scan and contrast to look for polyps without any invasive procedures. The downsides here are that you still do have to do a full prep. You are exposed to radiation, although it is a relatively low dose, and the interval is slightly lower every 5 years. After this, we really have our stool-based tests, which are also great alternatives for colorectal cancer screening. The two older ones are the FOBT and the FIT test, and these tests focus on looking for blood in the stool. The FOBT test has a higher false positive rate. So again, incorrectly identifying patients with cancer, or really just blood in the stool. Things like red meat. So if you eat a lot of red meat, this can falsely trip that test. The FIT test looks specifically at human hemoglobin, so it's a little bit better, a little bit more sensitive for colorectal cancer. And the last one, the multi-target DNA stool test, Cologuard. There's a picture of the TV ad in the upper right corner there. You probably have seen this ad on TV, but this combines FIT testing as well as looking for some genetic mutations, some of the more common ones associated with colorectal cancer. So I'm going to throw a lot of numbers up here. So this is looking at screening efficacy, so sensitivity and specificity. All these tests are very good, but there are some variation, as you can see, between the sensitivity and specificity, particularly when you're looking at the stool-based tests, sensitivity compared to colonoscopy. But the number that really is important to highlight here is this column on the right, and this is lives saved per 1,000 people over the age of 40 with colon cancer screening. And what you can see here is, although they are ranges, the ranges are pretty much the same across the board. So the takeaway point here, and we'll bring it up again, is just get screened. It doesn't matter which test you use. The number of lives saved is about equal across a population. So who should be screened? And this is a really important topic as well. Screening starts with a risk assessment. So this really should be happening in your primary care doctor's office or a GI doctor if you see a GI doctor, but determining if you're high risk or not. So patients who are high risk for colorectal cancer are patients who have a first-degree family member, so parent, sibling, children are also first-degree relatives, but typically this is not how we see things play out. So first-degree family member diagnosed with colorectal cancer at any age, that makes you high risk. Also, if you have a first-degree family member who has had an advanced polyp, so this is specifically a polyp found on colonoscopy that's large or has some microscopic features that are more concerning than a normal polyp. And usually this is a conversation that an endoscopist will have with the patient saying, you have a high risk polyp and you should let your family members know. And then there are also known genetic conditions, hereditary cancer syndromes, things like Crohn's disease or ulcerative colitis, which put patients at higher risk for colorectal cancer. And patients who have those conditions usually know that they have them and will be screened appropriately. The guidelines are slightly different for screening for high-risk patients and other patients. Usually the recommendation is or has been starting at the age of 50, now at the age of 45, but for high-risk patients, age of 40 is when to start. And this can also decrease, so you can go before the age of 40 if the person in your family has been diagnosed with a cancer or polyp well before the age of 10 years before the age of diagnosis, if that brings you lower than the age of 40. So for example, if your father or your mother was diagnosed with colorectal cancer at the age of 45, the recommendation would be to start at the age of 35. Everyone else is average risk. There's no such thing as low risk for colon cancer. So just know that no one is low risk, and the new guidelines here would suggest starting at the age of 45 with colon cancer screening. Now, what's important to know is for high-risk patients, the only recommended screening test is colonoscopy, whereas for low-risk patients, you can use any of those approved tests mentioned before. When to stop screening. This is another kind of contentious point. Society guidelines would recommend stopping at the age of 75, but patients are living longer these days, and I can't tell you how many patients I've seen in their late 80s or early 90s being diagnosed with colon cancer. So if you are healthy and have a long life expectancy and reach the age of 75, I typically recommend continuing with colon cancer screening. Very quickly, what do I do if my test is positive? If you have any screening test that is other than a colonoscopy and that test comes back positive, the next step is going to be to have a colonoscopy to rule out a false positive test and also diagnose whether it's a polyp or cancer causing the problem. If you do have a positive colonoscopy, there's a variety of different things that can happen after that. If you have cancer, usually you go see a colorectal surgeon. If you have a polyp, sometimes these can be removed endoscopically, or I should say often they're removed during the colonoscopy. And then you have a decreased interval of follow-up. So instead of going every 10 years, depending on the size, the number, and the microscopic profile of the polyp, you will come in sooner for a repeat colonoscopy. And lastly, this is just a graph showing how we're doing in the state of Vermont in terms of colon cancer screening. We're all the way up here, as you can see, 71% of Vermonters, this is 2018 data, we're getting colon cancer screening. Certainly that's above average in the United States, but not at the top, and we have room for improvement. So again, takeaway points here, as Dr. Anker mentioned, colon cancer is 4th on the list in terms of most common cancer and most deadly cancer. Screening programs can prevent colon cancer, but also identify cancer early when it's curable. And there are many options that do exist. So takeaway point here, the best screening test is the one that you do. All right, these are some resources, and thank you.
Thank you. All right, we have time for we have a few minutes for questions, so hopefully time for a couple of questions.
Yes, you can get colon cancer more than once. You are considered high risk yourself once you've been diagnosed with colon cancer. And we have a program in place if you've been treated for colon cancer to surveil you more frequently than the general population, so we can find those polyps or cancers sooner if you do develop them. So yes, Lynch syndrome, for people who don't know, is one of the hereditary cancer syndromes I alluded to in my talk. It increases your risk of colon cancer as well as other cancers throughout the body. And we do modified surveillance, meaning more frequent surveillance for those patients. Also, just as something we do now is universal screening for Lynch syndrome, in that whenever someone is diagnosed with colon cancer, we are testing for genetic mutations associated with Lynch syndrome. But yes, if you do have Lynch syndrome, you're diagnosed with cancer, you are at higher risk for another cancer diagnosis down the road. But part of your treatment may be there are ways of risk reducing your chance of another cancer down the road as well.
Just one more question, please.
Okay, I'm wondering whether or not there's any research on what the incidence of colon cancer in younger people is attributed to.
Yes, there is research. No, we don't have an answer. Usual kind of hypotheses are genetic and environmental combination, but we don't know why we're seeing it. And it's certainly not because we're screening younger people, because the screening younger people is a result of the recent rise.
All right. Thank you, everyone, for your attention today.